I was asked by Sidzil to talk about looking forward to the post-15 agenda, but I think in some ways I have to go over a little bit of many of the things that we've already discussed yesterday, because where you start this story has ethical commitments, and how we understand the future depends upon how we understand our past. So these are the three main questions for the conference. And I'm going to take a look at where are we now and how did we get here? And what do we really want from the sustainable agenda and how do we get it? And then at the very end, I'll answer a little bit about what research can contribute. So where are we and how did we get here? Well, maternal mortality has been, as you all know, a neglected topic in international health. The Safe Motherhood Initiative was launched in Nairobi in 1987 with 500,000 deaths every year. In the 1990s, it seemed like there was movement. There was a growing consensus on interventions. That old model that was mentioned yesterday of assessing risk was set aside for a new model that every woman, that obstetric complications were neither predictable nor preventable, and every woman needed to have access to emergency obstetric care. And at the same time, there were important UN conferences, Vienna, where women's rights were declared human rights, Cairo, where a whole series of different kinds of topics, from STIs to maternal health to family planning, were put together under an umbrella of reproductive health. And population policies were then meant to be directed not by demographic imperatives, but by women's choices and reproductive rights. Beijing built on Cairo, and really affirmed the need for political determinants that we've heard about quite a bit in the last couple of days, political determinants and changes to make women be able to enjoy their health. So together these conferences set out quite a radical agenda. And as you might expect, there was immediately a backlash. What Marge Baer refers to as the trifecta of conservative Islamic states, the Vatican, and evangelical Christians, which we are still fighting to this day. And at the same time, I would say there was a lack of integration, a lack of operationalization of the broad concepts of Cairo and Beijing into programs and policies. So things were repackaged with different names, reproductive rights, but they actually were doing the same thing, measured by the same outcomes. The mainstream development community at the same time was focused on waning foreign aid levels. The International Development Goals were set out in 1996, which had a goal on reproductive health. And then we all know the Millennium Declaration in 2000, the MDGs in 2001. The MDGs were derived from the International Development Goals, but they removed reproductive health. So MDG 5 was the only goal in the Millennium Development Goals that had anything to do with reproductive health, 75% reduction in MMR from 1990 levels. And MDG 5B was only added, those indicators were only added in 2007, halfway through the MDGs with enormous political fights. So what kind of progress? Well, there has been progress. There actually, in 2013, it said there were 289,000 deaths, but there has been marked progress in reduction of maternal deaths worldwide and in reduction of the global maternal mortality ratio. But that success needs to also be placed in context with some caveats. 20 of 25 countries with the highest remaining maternal mortality ratios that are least likely to achieve the MDGs are in sub-Saharan Africa. 62% of maternal mortality is estimated to occur in sub-Saharan Africa, and I'll come back to that. And also, the impacts of maternal deaths, the end point doesn't stop with the death of the woman. We have just completed at Harvard some research on the intergenerational impacts of maternal deaths, on how when women die in pregnancy and childbirth, what happens to the families. And it turns out that it's one of the worst possible things that can happen to children. That in 4 countries in Eastern and Southern Africa, 50 to 80% of the index children are dead by the age of 1. and they're plagued with nutritional and other morbidities, with psychosocial effects, with early marriage. It's an intergenerational cycle of poverty, which needs to be considered when we're setting priorities in resource-poor settings. So there's still a large unfinished agenda on maternal health. But I want to talk about whether it was gender-sensitive, people-centered, rights-based, country-owned, and equitable. Well, this has been also pointed out yesterday. Skilled birth attendance shows the largest disparities of any MDG indicator between quintiles. This is actually inter-country variability. Within a country, you can see the same thing with skilled birth attendance. So essentially, the people we were reaching with the MDGs were the low-hanging fruit, were the people who were already in social insurance schemes, were the people who were living in urban and peri-urban areas. They were not the most marginalized, the most rural, the most hard to reach. Accountability and country ownership. So these are estimates from the UN and from the IHME on maternal mortality in Nigeria. Nigeria accounts for approximately 14% of maternal mortality around the world. And really, from maternal mortality was in the goal itself, very unusual to have the indicator in the MDG goal itself. And it mobilized aid and attention. But it is a terrible indicator for national planning purposes. And that's exactly what it became. It became used for national planning and national ranking and holding governments accountable. And of course, you can't really tell. Was Nigeria taking the right steps, adopting deliberate measures to reduce maternal mortality? You need process indicators for that. And if you look at the process indicators, Nigeria wasn't doing all that well. So there was not really the kind of accountability that you would want by selecting those numbers and targets in the MDGs. Oops. So what about unintended consequences of the MDGs? Well, we've heard about this yesterday too, that there were narrow technical interventions as opposed to system strengthening interventions, even so-called family planning, or what I would call access to contraception, because most people want contraception not for family planning, but just to have sex, was left out until FP 2020 in 2012. Research in institutions, there was an enormous focus on measurement. It's amazing if you do a literature review during this period, the number of articles dedicated to counting deaths and counting maternal mortality ratios, which really displaced the larger political conversations that had occurred in the 1990s around what was necessary to let women go through pregnancy and childbirth safely and enjoy their sexual and reproductive health and rights. And there was a move toward MNCH and RMNCH. So there was a recognition that MDG4 and MDG5 had dispersed, disconnected initiatives, narrow interventions. We wanted a continuum of care. The PMNCH was formed in 2005. And of course, there is a need for integrating care. There's now a new initiative around ending maternal, neonatal, newborn, and child deaths. There will be more of this. But there is something lost in this, because women are more than our reproductive capacities and intentions. Women are and want to be full and equal members of society, whether or not we have children or want children. So the move from SRHR to MNCH lost something big. A lot of the other dimensions that didn't fit into MNCH were left out of the spotlight. We talked last night about abortion, legal and policy frameworks, and the need to change them in general, in terms of unpaid care, in many ways, were ignored during the MDGs. Attention to discriminated groups, excluded and marginalized groups, displaced women, for example, disability, all kinds of exclusion and marginalization were not really paid attention to because there was an incentive to go for absolute numbers and aggregates. and the connections between reproductive autonomy and broader social determinants, the need for women to have, for example, access to endowments and entitlements, as well as gender equality, were largely lost or not made. So what do we want going forward? Well, here I'm going to take a page from an article by Amartya Sen in the Journal of Human Development and Capabilities. The sustainability of what? Obviously, we don't want the entire world to rapaciously pillage the earth the way the North has done for decades and centuries. So we want sustainable consumption. But people are more than just consumers. We're more than consumers of energy. We're more than consumers of cell phones. We're more than consumers of health care. Now, Sen points to actually Gro Brundtland's commission from 1987, where she is one of the first to look systematically at sustainable development, where she sets out this idea of leaving the world as you found it. So talking about equity within countries and between countries, and also intergenerational equity, of having future generations being able to meet their needs, which is critically important. And he agrees with that, and so do I. But he goes on to say that there's actually yet another dimension of what we want, which he calls freedoms or capabilities, and I would call human rights. The idea that people are agents and subjects. And here I want to give a concrete example. On March 8th, on International Women's Day, I was fortunate to spend the day with a group of very impoverished, marginalized women living of ethnic minority, fighting a discourse of hatred as vehement as I've ever seen. And they were telling story after story of lack of access to sexual and reproductive health care, or abuse in healthcare settings. A woman who had had her water broken without permission and had been given an unnecessary cesarean section. A woman who was the victim of domestic violence and got pregnant, and after she had her baby and had serious, serious physical and mental problems, was completely ignored because that health care was not covered in the system. Another woman who desperately, desperately wanted an abortion because she could not raise her child, but couldn't afford to go to the possibly one place 300 miles away where she might be able to get an abortion. And there are two things to say about that. One is that these women were not in Nano, Malawi. They were not in Kigoma, Tanzania. They were in the United States of America, in Texas. And they're precisely the kind of people who were left out by the MDGs. The second thing to say about that is that the stories I just told do not encompass them or their whole lives. They are more than stories of being victims. They assessed their situation, they evaluated, they inspired each other, they became agents of change and wanted to remake their world. And that's the kind of thing that we want to sustain, in my view. We want to create the environments that enable people to remake their worlds, to be agents of change. So looking forward, what do we want in terms of the SDGs themselves? We certainly want to embed sexual and reproductive health and right and gender equality across goals and not have them siloized. We want cross-cutting approaches, alternative economic models, and by this I do not mean privatization and PPPs. I mean questioning the hegemonic grasp of neoliberalism in development. We want universal sets of goals that apply to the North as well as the South, with differentiated obligations, including extraterritorial obligations. And we want to connect to civil and political rights and meaningful accountability mechanisms at global levels, so the high-level political forum, but also at national levels, courts, national human rights institutions that need to be financed in order to be meaningful. Targets should be differentiated by development level, or otherwise they're quite useless. National ownership, yes, but that also needs to be balanced with transparency and public justification, because national governments can be equally opaque with respect to data and health information as global entities. And equity needs to be hardwired, which means more than just disaggregating indicators. Indicators should be both qualitative and quantitative. If we care about institutional and legal changes, then we need qualitative indicators as well as quantitative ones. They should be fit for purpose. So we should look at unintended consequences and perverse incentives. I just said not everything requires disaggregation. You disaggregate contraceptive prevalence or unmet need for contraception, and you find in practice that low-income women are having long-acting and permanent methods stuck in them with what is not really informed consent. And the same thing with adolescent birth rates, I'm afraid, to get high yield couple of years protection. Balancing data availability with other imperatives. We know from the MDGs that if there is enough political pressure, you can make new indicators. In maternal health in particular, we know that some of the indicators we use are absolute garbage. We know which indicators tell us whether governments are taking policy relevant measures, and we are not using those indicators. But we could fight to be. So these are the indicators that have been suggested. These are not necessarily the final ones. These are UNFPA and other UN agency indicators. Let's see how we're doing. Well, maternal deaths per 100,000 live births, maternal mortality ratios is still there, skilled birth attendance is still there, which is still as likely to become institutional delivery. Adolescent birth rate is there for access to sexual and reproductive health services and demand satisfied with modern contraceptives. We'll see what happens with those things and how they're calculated. Target 3.8 is likely to have more indicators than are shown here about catastrophic health expenditure. We'll see if any notions of quality of services actually gets built into that universal health service coverage, real access to care and quality of care. Goal 5 also includes some sexual and reproductive health. These indicators are going to be very hard to measure. We'll see what kinds of measurements they actually include at the very end, and how much attention each of these different goals gets when all is said and done. Because certainly in the MDGs, one of the lessons learned was that there were poor cousins goals that didn't get a lot of attention, while other ones got huge amounts of funding. So all in all, I would say it's a mixed bag on the SDGs. A lot more goals, 17 goals, a lot more targets, 169 targets, a lot more indicators. Is it a Christmas tree where nothing is going to get focused on? Well, the lesson from the MDGs, I think, is not that simplicity is the way to go. The lesson from the MDGs, I think, is that you can make targeted progress, but there is a cost. And a nested structure of goals, targets, and indicators does not make for a transformative development paradigm. So how can we assure a priority on women's and children's health within the post-2015 agenda? You know, I think some things, like the research that we have done showing how terrible it is when a woman dies in pregnancy or childbirth, and what that does to children and families, is useful, even in a utilitarian, conventional public health sense, to say when you are setting priorities, these are the kinds of factors you need to take into account. But I also think really putting a priority on women's and children's health and rights means changing the frame. Changing the frame to one of an old frame, the Universal Declaration of Human Rights, and making the conditions those in which all people in social and international orders can realize their human rights. Now, the last question, how research can contribute to this approach, my answer to that is that we should start asking big questions. There are a lot of little questions that we ask in public health all the time. What's the best clinical protocol to set on cell phones so that women can get into prenatal care and obstetric care quickly? Things like that are necessary. What are the best incentive ways, programs for healthcare workers? Those are important questions. But there are bigger questions, I think. And one of the biggest questions is how we are allegorizing our world and how that frame determines the opportunity structures of different actors, donors, government policymakers, programmers, providers, and conduct at all of those different levels, and doing empirical hypothesis testing as well as normative work on those kinds of questions. So in 2030, we aren't asking exactly the same questions we are now. At the next session, I'll be talking about a book launch where Sakiko Fukuda Parr and I did a book looking critically at the MDGs framing. And we are now wanting to do a project prospectively looking forward at the SDGs. And I think all of us are practically to do the best public health work we can do, but also ethically are required to think about how our paradigm shapes what is possible and not possible in public health. Thank you.